time, I'm gonna make it really short. We have another speaker from Egypt, Amr Asker, please.
It's a great pleasure to be with you today. Thanks, Anna. You did a great job today.
You're welcome.
Yeah, thank you. It's a great pleasure to be with you today in this fantastic venue. I'd like to thank David, Roberto, and Francesco for this great event. And from 9 months when David told me let's make a simple ortho meeting, I supported him. Let's go from the Facebook group to the reality. It will be beneficial for all of you. And I don't know why I'm having today a last lecture. I think it's the 12th time in my life when lecturing to have this last lecture in the day. May I have bad luck in life? I don't think so. So today, I think after lunch you'll need to sleep, but I try to make you wake up. Today our lecture will be about orthodontic management in back teeth. I don't know how to summarize yesterday's workshop, 9 hours and 45 minutes. It's so difficult, but I tried. And for yesterday attendees, I promised him that I will get him something new today in this lecture to be something like interesting lecture, not so boring. So, I'm Amr Asker, I'm from Egypt. I had my bachelor degree in Mansour University, and after that I finished my postgraduate studies. First of all, I have several studies. The first thing that I have finished, it was a maxillofacial surgery diplomate. It was in Cairo University. And after that I have joined the master's degree in Vienna University in Austria. And after I finished my master's degree in orthodontics, I started to think I'm falling in love in back teeth extractions and also perio combined treatment. So I think, why not to have an perio master ortho? And from 1 month ago, I have finished my master's thesis in periodontics. As a periodontist in periodontology in Mansour University, which is my home. And today we will discuss the back teeth management from different topics. Different topics from the flap to the traction techniques, bubble wire mechanics, and how to deal with harsh impacted teeth and tough impacted teeth, by the way. Because not all the impacted teeth is so easy. This is Egypt, as you know, in North Africa. I think there's probably sound. And as you all know, we have the pyramids and Hurghada, Sharm el-Sheikh for diving, if you are interested. And you can have a safari in the desert. It's like a famous song in Egypt. I think you will like it. This is the pyramids. I advise you to visit this place and to go to Hurghada to have a relaxation and sunny weather. Okay, this is our team, and today I have both of my team, which is Mamdouh and Sharif. Our lecture today will be about impacted teeth, but before going to inside the lecture, I need you to think about something. Which one of them is most important? Is it the certificate, or the experience, or the knowledge and science, or the confidence? Which one is better for you? Or to get first? Yeah, you? What? Confidence. No, I have many of my friends that have confidence, but very bad cases. And the patient says thank you. That's the problem. I think in my mind, and that's what I thought about after finishing my bachelor degree, is to have the knowledge and science. And after having the knowledge and science, you should have the experience, but a good experience. And after having the experience, you will have a confidence. And after that, if you cover all of this with a certification, it will be so good. But the knowledge and science should be updated. Not every year, it should be updated every month. Because today's knowledge may be our tomorrow's mistakes. Our today's lecture will cover diagnosis of the impacted teeth, and then we will pass on treatment strategies. After that, we will discuss some of the clinical implementation and techniques and tough impaction cases, how to deal with horizontal impactions. I think CBT will burn a lot of my lecture today, because it was the same topic, but I think it's different mechanics because he's following cantilever mechanics and loops, and we'll discuss today some different mechanics and what's the difference between TVDino lecture and my lecture. When can it be considered impacted? A tooth that was prevented from eruption and its dental age has passed is considered impacted teeth. And in our practice, the impacted teeth cases should be about from 8% to 35%. So different from practice to another, from country to another country. The impaction etiologies may be like abnormal eruption bath, no eruption bath like horizontal embarkment bath. Sometimes also we have a supernormal in the bath of the eruption, like odontome, like in this place, in front of the bath eruption of the central incisor, and in bath eruption of this right cuspid. And also from the etiology, the crowding and lack of space. If you notice here, the upper left cuspid, it hasn't any space between the lateral and the fore. Also, you should open space and get it out. Sometimes the cause of impaction is the dentigerous cyst. And this canine has a large dentigerous cyst around, it displaces the lateral incisor and a little bit resorption in the retained C. What do you think about this case? But not to yesterday attendees. Okay, our new attendees. Is it to refer for a surgeon or for an orthodontist or a periodontist first? Okay, can orthodontist solve this problem? Exactly, yes. Because if you make stabilization for this large cyst and get this retained C out, you can get it back easily in its place. And after I finish my treatment, there is no reason to extract this cuspid. Also here, I had here lower left impacted 5 and a large dentigerous cyst. The only thing that I did to remove this deciduous molar and to get the 5 out, and during extracting the D and exposure of the second premolar, I did some stabilization and removal of the cystic wall. After traction, the bone is forming in the place of the second premolar and no obvious surgeries. Only one surgery and frontal traction of this impacted bicuspid. And here, dilation is also a cause. Our right central here has a dilated root. If you notice it here, the apical third of this central incisor is dilated gingival. So it's prevented from eruption intraorally. And abnormal eruption bath of upper right premolar here is horizontally impacted. It's known that supernumerary tooth removal, as early as possible, will decrease the chance of the impaction and allow the auto eruption of the impacted teeth if done before the age of 10 years. At the age of 10 or before the age of 10, if you notice supernumerary in the back central incisor or even the canine, and you remove the supernumerary, the chance of auto eruption will be easily. And after 10 years, if it didn't erupt, you can go for orthodontic therapy. Also, the surgeon during the removal of impacted teeth should keep the follicle of the permanent tooth intact as possible, as many research prove that the follicle has a great role in eruption process. Mark Ital had researched in this area and reported that the integrity of the dental follicle is critical to the normal eruption process. Sometimes you can leave the follicle intact, but in the other times, when superimposed on the lateral incisor, it's difficult to preserve the integrity of the permanent incisor. Here in this case, the patient came to the clinic with a supernumerary and the path of eruption of upper left central incisor. And after I removed the supernumerary and I waited till 2 years after removal, the patient came to me at 10.5 and the central incisor started to erupt here without any orthodontic intervention. So just remove the cause and wait for auto-eruption. After 10.5 years, you can go for orthodontic therapy if needed. The most commonly affected teeth in our practice is the wisdom tooth. And as you know, wisdom tooth has a little bit role in orthodontics. The next one, which works a lot in orthodontics, is the maxillary canines, maxillary cuts. And the next one, maxillary and mandibular premolars, and lastly maxillary central incisors and molars. From diagnosis, the first thing, you should diagnose impacted teeth bulge patient and searching for bulge and palpation. And when during the palpation, you should notice if there's rough bulge or smooth bulge. Because if you have a smooth patch, it's indicated that there is no bone covering this impacted tooth. And if you've noticed that there is a rough patch, and you can notice that also by explorer, just topical anesthesia, and it says explorer and make the feeling of the canine. Is it smooth or rough? And it will help you a lot in choosing the proper flap design. Because if you have bone, you need to remove the bone, so the flap will be changed. And if you don't have bone, it's easy to do like gingivectomy or open eruption mechanics. Just mark the location. And then the third step after inspection and palpation is to go for CBCT. And as you know, you have panoramic and spirometric X-ray for all cases, and now CBCT should be done in any impacted teeth. It's not only for localization. Impacted teeth will help you a lot to detect any lateral resorption or any neighboring adjacent teeth resorption. Also, you can use a little bit information about the bone density and the path of traction to design how many years this case will take from you. Also, any dilation in the apex, the professional orthodontist not look only for the crown. He should look for the root. In my practice, when I have an impacted teeth, I usually follow the crown, then follow the root till the apex, till the foramen. And follow the dental follicle of this tooth and follow the periodontal ligament space to diagnose if there is any chance for ankylosis. And if it's ankylosed, is it a partial ankylosed or completely ankylosed? After that, the CBCT will diagnose the location to have a perfect technique for exposure, as you have axial, sagittal, coronal cut. So here, you know that when you remove this bone, 2 mm bone labially and 2 mm bone from the crest, you will find the crown of the canine in its place. This literature was about the resorption of incisors after ectopic eruption of maxillary canines. And it was reported that from these cases, 107 children with 158 ectopic erupted maxillary canines, 48% of the children had resorbed incisors. And the resorption occurred mainly before the age of 11 to 12 years of age. And later resorption occurred after this age. Before this age, the erupting canines has a more force for eruption. And this pressure on the lateral incisor can cause resorption on its root. As in this case, you have an impacted canine here, and from diagnosis, we have a resorption in the lateral incisor, and after tracking the canine to its place, we have like a half of the root of the lateral is present, and the half of the root is not present at all. So from the beginning, you should inform your patient that you have a bad prognosis lateral incisor. Okay? If you didn't tell him that, and after finishing, the patient came to you look like you are a bad orthodontist. Okay? And if you need to persuade him that he has a resorbed lateral from the beginning, he will not believe in you. About the treatment strategies, the same preparation like traditional cases, cause removal, go for leveling and alignment, okay? Plus some tricks in impaction. The first one is to think about the exposure technique, the surgical tricks. The second thing is to think about the attachment. What attachment you will use during traction. And after putting the attachment, which technique will you follow when you follow in traction? If you follow the double wire mechanics, power chain traction, and the anchorage. If you will use TADs, cantilevers, micro implants, which one's anchorage devices you will use? The exposure techniques maybe depends on the position of the impaction, labio buccal, and also depends on the position of the impaction medial distal. If the canine is above the lateral incisor, it will be different. And proximity of the impaction to the midline, impaction level incisor gingivally, and the relation, which is more important part, the relation of the impacted canine to the mucogingival junction. It's more important part. It will help you to diagnose from open eruption technique to closed eruption technique. 3 exposure techniques. One of them is open eruption technique, like gingivectomy, and second one is apical reposition the flap, and the third one is closed eruption mechanics. The first one is open traction technique, also by laser and scalpel or electrocautery. It will be easy. Like small exposure here, and start to track this canine in path of traction. So here, I have 2 impacted cuspids. I just open a window on the impacted tooth by electrocautery after level the alignment of all teeth, and I have just a small piece of power chain to track this canine in its path in the same occlusal plane of other teeth. And it was tracked easily and came in the path. And when you are noticing this technique, the advantage of this technique is easy to perform. It's like laser or electrocautery and opening a flap. Less traumatic for the patient, no need for suturing. Also, the disadvantage of this technique that we have a more risk of gingival recession and a possible damage to the periodontium, especially if it's done with unprofessional orthodontist. And the last thing from the disadvantage, that we have a risk of gingival overgrowth at the surgical site. And at the end, if you not follow this technique properly, you will have a long clinical crown at the end of treatment. Never to use this in high labial impaction central incisor and cuspids, especially central incisor. The second type of flap is apical repositioned flap. Apical reposition above the impaction and to raise the flap apically, and after that, to prevent the flap from coming down again, you should do a suturing medially and distally. And after exposure, you